Thank you for the organizers to invite me here today. It's early in the day, had half a cup of coffee. I apologize in advance. So I will just focus on the Canadian landscape of things and the pyrophosphate imaging today. These are my disclosures. The topics I will cover will include nuclear imaging of cardiac amyloidosis, exploring Canadian landscape, and a couple of initiatives that I've been fortunate to get involved with Dr. Reddy, and so I'm fortunate to be able to pay my tribute today. So cardiac amyloidosis is one of the causes of restrictive cardiomyopathy by infiltrating the myocardium with misfolded protein deposits termed amyloid fibrils, causing a clinically diverse spectrum of also systemic diseases. There are two protein precursors. One of them is the light chain produced by bone marrow plasma cells, and the other one is the TTR, is a serum transport protein for thyroid hormone and retinol synthesized primarily by the liver. The TTR could be a wild type, de novo, or hereditary running in the family. So the clinical red flags and diagnosis are diverse, and I will just get to this next slide. But biopsy, as gold standard it is, it has a low yield, however, has 100% accuracy and an invasive for diagnosis of TTR versus AL. For AL, it requires demonstration of light chain amyloid fibrils in the tissue. And for TTR now, we have imaging plus minus biopsy for diagnosis. So Canadian Cardiovascular Society and Canadian Heart Failure Society had a joint position statement in 2020 on the evaluation and management of patients with cardiac amyloidosis. And these are the, is this the pointer or no pointer? No pointer. Okay, well, these are the red flags basically on the picture, but they recommend the diagnostic workup for cardiac amyloidosis for patients who present with signs and symptoms of heart failure who have one or more of the following features, which are unexplained increased alveolar wall thickness, greater than 60 years of age with low flow, low gradient aortic stenosis and EF greater than 40%, unexplained peripheral sensory motor neuropathy and or dysautonomia, history of bilateral carpal tunnel syndrome, and established AL or ATTR amyloidosis. And they also recommend performance of nuclear scintigraphy with bone-seeking tracers to evaluate for cardiac involvement when ATTR cardiac amyloidosis is suspected after exclusion of light chain disease. So the diagnostic algorithm the society recommends is basically it starts with the clinical suspicion, and then it's a tiered approach of screening for plasma cell dyscrasia, basically looking for light chains in the serum and urine. And then if TTR amyloidosis is suspected when monoclonal protein is absent, doing the PYP scan. There are other tracers available in the States and in Europe, but in Canada we use PYP. So once the nuclear scan is done, if it shows, if it's positive, then you go to the next step to do a genetic testing to see if it's wild type versus familial. Once it's excluded or equivocal, you can actually move into a more invasive like diagnostic biopsy. So in diagnosis, there are serum biomarkers and imaging really plays a very important role because the serum biomarkers may remain relatively non-specific. And in imaging, you can capture the cardiac functional impairment caused by amyloid infiltration, and you can afford insight to hemodynamics. And imaging also has potential to directly visualize the remodeling, as well as potential to actually follow up response to treatment. So pyrophosphate has been around for many years, I guess, since maybe when I was in high school or elementary. and it has been used for cardiac amyloidosis imaging. However, due to lack of therapies, I guess it wasn't as popular as it is now. With the rise of new therapies, growth of new therapies, now the scan has gained more popularity. The concept actually garnered attention in 2016 when a team from Columbia University examined 171 patients who underwent evaluation of cardiac amyloidosis from 2010 to 2015 in multiple centers. And the PYP imaging at the time demonstrated 91% sensitivity and 92% specificity for detecting TTR amyloidosis. And this is and there's a very nice review article from Dr. Maurer from Columbia University regarding the bone-seeking scintigraphy, its potential applications and diagnostic value. And these are the multi-societal guidelines also for indications of nuclear scan. I would like to add a couple of additional things to the cardiac society, to the Canadian Society, for the gene carriers. The indications, the appropriate use also includes gene carriers with no cardiac symptoms. Asymptomatic gene carriers, apparently pyrophosphate imaging is appropriate to screen them. And it's also appropriate to rescreen them for recurrent testing. Again, for new or worsening cardiac symptoms in these gene carriers, you can also appropriately scan them and rescan them for follow-up. So the treatment options are a few. There are silencers, which act on the liver to decrease the production of TTR, stabilizers, which in turn prevent it from the amyloid fibrils from breaking apart and forming fibrils, TTR from breaking apart. And then there's fibril disruptors. These medications may help break up and clear TTR amyloid fibrils. And there are a couple of other treatments that have been tested in small studies. And there's a potential antibody that removes TTR amyloid fibrils called PRX004, and it's also being tested in clinical trials. And as a last resort, I guess, because TTR is made in the liver, a liver transplant is also a possible treatment for patients with some hereditary forms of amyloidosis. And so the Canadian Cardiovascular Society recommends tafamidis, that is a TTR stabilizer, for patients with TTR cardiac amyloidosis and NYHA class 1 to 3 symptoms. And they recommend a silencer, inotersen or patisiran, a silencing agent for patients with hereditary TTR amyloidosis with ambulatory polyneuropathy. So Canadian landscape in the imaging, we have Canadian Association of Nuclear Medicine that came up with guidelines in 2021 that nicely actually describes the imaging protocols and processing as well as interpretation. And you can find it online, actually. I gave the link there. So it starts with the patient preparation, which is none. And the pharmaceutical, you can use 10 to 20 millicuries of pyrophosphate, depending on your patient's weight maybe, or the imaging that you're going to perform, which involves SPECT or SPECT-CT imaging in addition to planars. You always start with the 1 hour planar image, which we're recently finding that 1 hour planar images have quite a blood pool activity still. So addition of a SPECT or SPECT-CT afterwards is recommended. And you can also do, if needed, a 3 hour planar image. And these are the imaging parameters, as you can see. There's a low dose CT parameter as well for the attenuation correction and anatomic mapping. So this is an example of a patient with the 2D, two-dimensional planar images where you put the region of interest over the heart and the contralateral lung to come up with a ratio. The magic number suggested initially was 1.5. If the ratio is greater than 1.5, you confirm your diagnosis, and then here are the SPECT and SPECT-CT images to actually increase your confidence and see the distribution of pyrophosphate in the myocardium. So the guidelines describe the planar imaging with limitations because it only allows visual assessment and visual and planar quantification of tracer uptake. As I said, that magic number may not be always there, and you may end up with quite a few equivocals. Two-dimensional imaging also does not define the regional differences in tracer deposition, which might be significant. We will see it in the further slides. And it does not account for tracer uptake unrelated to amyloidosis. SPECT imaging, therefore, particularly with CT attenuation correction and anatomic mapping, overcomes these limitations. It can determine the exact localization of the tracer uptake. SPECT and particularly SPECT-CT images allow a more quantitative tracer uptake by a generation of polar maps and raw counts in the determination of relative tracer intensity. So when you acquire your SPECT and SPECT-CT images, you can actually process them on the workstation, come up with and do oblique, we call it an obliquing of the slices to come up with short axis, horizontal long axis, and vertical long axis slices, just like in the regular cardiac processing. And you can then identify the tracer distribution in myocardial segments. You can, with the conventional full chest SPECT-CT, you can derive, you can process it as if it's a cardiac scan and come up with polar maps, or you can acquire it on a CZT SPECT and come up with a nicer image, I guess, as a dedicated cardiac SPECT. However, these are good for when everything is clearly abnormal or clearly normal. And when things are equivocal, it's a different scenario, which I will mention. So with the procedure and parameters, just before I forget, in terms of screening and rescreening, the total body effective dose from an average of 15 millicurie of pyrophosphate is estimated about 3 millisieverts. And the low-dose CT will approximately add 2 millisieverts. Smart CT protocol could give lower doses. In our institution, actually, this dose is less than 1 millisievert. So if anybody is worried about the radiation in terms of screening or rescreening, it's just the radiation is the least that you could worry. Least of the issues. So in SPECT-CT, the important things to recognize, where are the counts coming from on the planar images? So are they coming from the blood pool? Are they coming from other structures within the thoracic cage? Are they coming from, I don't know if you can see, there's a fracture in one of the ribs, and there is quite a blood pool activity on the right side. These things all can skew your heart to contralateral ratios. And sometimes you may not reach that magic 1.5 numbers because of the heart anatomy, and the left ventricle could be quite a different spot than you expect, and you may not get your 1.5. So I think I'm trying to say that we do not rely on planar ratios for actual interpretation and diagnosis. So we have seen over the years various distribution patterns on our SPECT-CT images. And these are important to note because amyloid is not really a big bang, that it's not there yesterday and it appears today diffusely. It may actually gradually, it's a gradual process. It occurs, it accumulates over time, and it may start focally and it may be diffuse in majority of the cases. Or it might be focal on diffuse. We can see almost all segments involved, but with the septal predominance. It can have a low-grade diffuse uptake. It can have a very low-grade diffuse uptake. And again, I highly doubt you will reach that magic 1.5 with these images. On the planar, you will not see a 1.5 ratio. And you can see the apical sparing on this image. So that's why it's important not to rely on just planar images, but get a three-dimensional approach. So Canadian guidelines recommends SPECT-CT when available. SPECT and SPECT-CT imaging can differentiate between the pyrophosphate uptake in the blood pool and the myocardium as well. It can give you an understanding of distribution. So for the interpretation, you can, the impression involves either normal or abnormal study. Is it a positive scan or a negative scan? And is it suggestive of TTR, cardiac amyloidosis, or is it equivocal, or is it not suggestive? And of course, recommend additional evaluation as appropriate. We go back to the Canadian Cardiovascular Association guidelines that you always have to rule out light chain disease. So just an example of this, two different patients with same heart to contralateral ratio of 1.4, and one of them has amyloid and one of them doesn't. When you look in depth with the three-dimensional images, so the first patient, you can clearly identify the distribution of pyrophosphate within the myocardium. You can see the silhouette. And the second patient, you can see it clearly in the blood pool. When you do your visual grading, they both actually grade almost like grade 2, 3, but in the second patient, does it even matter what grade it is? Because the tracer is not in the myocardium anyway, so it's in the blood pool. It may be greater than rib uptake, but as long as it's not in the myocardium, the scan is negative. With the SPECT-CT, you can clearly then see. And again, it's really good when you're in doubt. CT provides a very good roadmap for your confidence, and it increases your accuracy. So more into Canadian landscape. I was fortunate to be involved in a multidisciplinary advisory board meeting about 3 years ago to discuss issues around diagnosis and management of TTR cardiac amyloidosis. And this was a huge opportunity to improve patient care across Canada. Multiple specialties across multiple sites in Canada were gathered on a Zoom meeting because it was 2020. And we discussed about PYP supply chain, transfer of knowledge from academic to community. We talked about research gaps and opportunities and the future of imaging for cardiac amyloidosis in Canada. And the advisory board came up with some goals, short-term and long-term goals in development and publication of practice points, harmonized image acquisition interpretation, reporting and terminology, where the Canadian Association of Nuclear Medicine guidelines shortly followed, and educational programs for both nuclear and non-nuclear medicine physicians on SPECT and SPECT-CT imaging for knowledge translation and increase awareness. And in the longer term, we plan to develop a Canadian cardiac amyloidosis pyrophosphate imaging registry, where Ottawa is one of the sites, the core lab sites. And this will be a stepwise approach, starting with building a framework and moving into collection and analysis of outcomes data. So again, I would like to pay my tribute to Dr. Reddy in all these. He has been instrumental in actually implementing these initiatives. So the registry is on its way, and then the educational sessions are already started. So the registry is called CAPER, the Cardiac Amyloidosis Pyrophosphate Imaging Registry. This is spearheaded by also Dr. Miller in Calgary, who works with Dr. Fine, who on the clinical side. And we are planning on, already actually planning on transferring the data. There are 6 sites across Canada are involved and committed. And so hopefully we will have a better understanding of cardiac amyloidosis in Canada, across Canada, and how to diagnose and how to come up with better management and algorithms. So this is the second initiative that Dr. Ruddy has been instrumental in. And we have an educational research grant, and we piloted in Ontario to reach out community hospitals and imaging centers to, again, increase awareness, improve their imaging protocols. It's called QI CAPES, And Dr. Reddy came up with these logos himself, actually, which in the end we didn't use, but I thought it would be nice to put here. So this is a quality improvement project in cardiac amyloidosis pyrophosphate studies. We reached out about 22 centers across Ontario. And here, actually, these are the people who helped me, Dr. Miller and Dr. Reddy. We held our first webinar in September. And it was really a big success. It turned out that there was a big appetite on learning about cardiac amyloidosis and learning how to image properly. All the community centers that attended the session, actually the polls predicted that their equivocal studies would significantly decrease after this session. There was no fancy venue, there was no food involved, but we managed to gather so many people. So we realized actually this will be an ongoing educational plan. So there was excellent participation. As I said, there were lots of questions, lots of interactions. We planned it as a 1 hour, but it went way over because of the questions that were asked. And again, we did polls after the session to predict decrease in equivocal cases. So we're also planning to help provide overreach to new sites and support good PYP imaging practice in Canada. And there's already work going for that. And if anybody interested in the audience, from if you are just implementing it, or if you have equivocal cases, things that cases you're not sure about, we're happy to provide overreads. Dr. Reddy is right here. He's so we're just let it reach out. We are here, and this will be also an ongoing project for ad hoc reading. So with that, I thank you. I managed to finish on time. Thank you.